Gloria, can you put these slides on the screen, please?
Yes, so it should be on now. Please let me know if you can see my screen.
It's a blank. Oh, yes, it's come up. Thank you, Gloria. That's great. I can see it now. I think we'll make a start. Welcome all to the Thames Valley Cancer Alliance Prostate Diagnosis and Follow-up Lunch and Learn. It's going to be online, obviously, and it's hopefully going to last no more than an hour, so you can have a bit of your lunch back. Next slide, please. I'm Dr. Anat Sashdev. I'm the Thames Valley Cancer Alliance Primary Care Lead and a CRUK GP. And today's agenda is pretty full, but we want it to be very interactive. What we want to do is share with you some data on prostate cancer. We want to talk a little bit about what prostate cancer means and how to prevent it. A little bit on diagnosis, quality referrals, and secondary care. We won't have time for questions and answers, but obviously we want to make it interactive. However, please put yourself on mute and also off camera. If you have a burning question, please put your hand up. I really appreciate that. That hopefully won't interrupt the speaker. And I'll try and take the questions as we go along. First of all, I'd like to introduce Zahid, who's the Senior Data Analyst for the Alliance, who's going to give us a little bit of background on prostate cancer cases and mortality across the Thames Valley Cancer Alliance. So over to you, Zaid.
Okay, let me share my screen. Let me know if you can see my slide.
Yes, can do. Yeah, it's not in slideshow. It's just in normal. A slideshow would be easier, I think. Thank you.
Yep. Can you see it? Okay.
Yes, very well.
Right. I'll not take a very long time. I'm not a very technical person, so I'll quickly run through a couple of slides all about prostate cancer data. Just one thing to flag: all data have been taken from CancerStat, which is part of NDRS NHS England now, and they all analysis have been taken for TVCA area, not at the national level. So from the left-hand side, this one is 20-year data. This is total cases, prostate cancer data at TVCA area. And the top one is age standardized rate. So from this line chart, you can obviously see that prostate cancer is increasing over time. At TVC area, there are a few deep over there, and in recent 2 year, 2019 and 20, there is a decreasing trend. But this is obviously because of the COVID reason, because we saw a similar type of trend for other cancer and referral as well. And the similar pattern for is standardized case rate as well for prostate cancer. And the right-hand side figure, you can see the same cases. The mortality is also increasing is over time. But interestingly, if you see the age standardized mortality rate, it is a little bit decreasing. So probably it is medical advancement. You are clinician. I mean, they can answer this question. And for the second one, it is prostate cancer prevalence analysis. So first left hand, you can see it is prostate cancer prevalence in 2020 by cancer site, TVC area, obviously. So from this bar chart, you can see the topmost prevalence is breast cancer, but prostate is not. It is second most, which is over 10,000 population at TVC area in 2020, and the other cancer site you can see over there. And if you see the time series analysis for 10-year prostate cancer prevalence from 2010 to 2020, it is definitely increasing. You can see it is obvious. It is increasing every year, and it's a bit slow with 2020, probably because of COVID as well, like what I showed in my previous slide. The second one is the prostate cancer prevalence, like this one, but it is breakdown by ethnicity and IMD. So for prostate cancer prevalence in 2020, the left-hand figure, you can see it is the mostly from the white background people, and there are a few people around 1,500 are unknown. Probably they did not declare the ethnicity. And the right-hand side for the IMD, it is almost most deprived population, and the least deprived, sorry, not most deprived, and there are few from most deprived. My last slide is prostate cancer survival rate at TVC area. So left-hand side figure, it is 1 year and 5 year survival rate for prostate cancer at TVC area. And this is, but you can see that, it is slowly increasing, the survival rate, both for 5 year and 1 year. Obviously, maybe because of medical advancement, probably you can answer. And from the right-hand table, if you see the, by age group survival rate, it is highest between 15 to 55. It's almost 90 over 99% for 1 year survival rate, and it is decreasing for older population. It is lowest between 85 and 99. It's around 75%. And for 5 year survival rate is a similar pattern. Is highest for younger age group. I mean, 15 to 55, and a decreasing of for older age population. There is no data for 85 to 99 because of very low data. So yeah, that's all from my end. Thank you.
Thank you, Zaid. Useful sort of presentations for the Thames Valley Cancer Alliance. If you've got any questions, please put them in the chat and we'll try and answer some of the data questions. I think quite a lot of analysis on this data is being carried out to see whether there is any access issues or awareness issues that people aren't coming forward. If you have any questions, please put them in the chat. That'd be really great. Thank you, Zaid. Next slide, please. So I really want to introduce to you Mr. Tom Leslie, who's a urology surgeon from Oxford and Milton Keynes, who's going to tell us a little bit about prostate cancer diagnosing and prevention and risks and facts and figures. Over to you, Tom. Thanks.
Thank you, Anand. Yes, I'm Tom Leslie, and work half the time in Oxford and a bit of the time in Milton Keynes, delivering the prostate cancer service there. And thank you for having me today. So you've already seen the stats for the region, which were actually quite telling, really, weren't they? So there is an increase in diagnosis, but probably not a big change in survival over the last 10 to 15 years. And overall, 1 in 8 men will have prostate cancer. And the prevalence goes up as we get older. The mortality overall figures always look quite alarming, 12,000 a year. So prostate cancer is one of the biggest affecting cancers for all people. The lifetime risk of death from prostate cancer is a bit lower. So only 3.5% of men will actually die of prostate cancer in the end. And as we saw from those local stats, which are probably more relevant actually than these big national stats. 5-year survival for men in their 50s, 60s, 70s is well over 90%, and for those men in their 80s, prostate cancer may well go on death certificates, but I suspect it's not always the primary cause of their death. However, being diagnosed with locally advanced or metastatic prostate cancer is a different scenario and confers a higher risk of further metastases or death as well. So the stage and grade is very important. Now, am I able to put, I can move it forward? Yeah, that's great. So I thought we'd talk about, first of all, we talk a bit about risk factors, because, and then we'll talk about PSA and all those kind of things a little bit later. But risk factors are, I think, one of the things that's a key, and you will all be aware, in fact, there was big articles in the BMJ this week, I think, about prostate screening, prostate cancer screening, and the pros and cons. And in the conclusion that there's no one right answer, and prostate cancer screening probably leads to over-diagnosis and over-treatment, but not allowing men access to PSA treating and diagnostics probably means we miss some of the important people. So as a group of clinicians, we need to be pretty strong on what the risk factors are and who we really should be helping to gain access to prostate cancer diagnostics. So first of all, age. All of us get older, and age is the most significant risk factor for prostate cancer. As men get older, the more likelihood of them having prostate cancer. I haven't put it on here, but the old adage is 90% of men over 90 will have prostate cancer. That's based on cadaveric sampling of men who've died of other things, looking at their prostates. But it is so going the other way, though, it is very uncommon in men under 50, with a few provisos in terms of some of the other risk factors that are coming up. Family history is important. So one first-degree relative increases a man's risk by 2, relative risk by 2. 2 first-degree relatives by 4. If there's an element of hereditary prostate cancer, and I've put in at the bottom of the BRCA2 gene, which is included in all that, then it probably increases it by 5-fold. And the BRCA2 gene in particular, 20 to 40% chance that that man will have prostate cancer in his life. So we don't always know about the BRCA2 gene, but obviously if we're aware of that, that puts a person into a higher risk category for increased monitoring in terms of case finding. The family history, not everybody knows it, not every patient knows their family history very well, but it is worth just trying to pin them down and say, do they know about their father, uncles, brothers? And then the flip side is they often will come and ask after they've been diagnosed with prostate cancer, do their children need to be terrified? And I tend to say, look, if someone's been diagnosed in their 70s, then the familial element is relatively low. But if someone's been diagnosed in their 50s, then that's something that, again, raises another slight red flag about how you would advise their children as to what they do next. And we're not talking about PSAs in the 20s and 30s. We're saying strong family history, having a PSA check, probably age 50, rather than waiting until another time when they perhaps have a few symptoms. Race is the other really key thing that I think we need to dwell on. And I was interested in that slide from the beginning about the proportion of prostate cancer allied to ethnicity or race at the start. Men with African or Caribbean origin, black men, have double the mortality and double the risk of having prostate cancer of white men, and white men actually have a higher risk than Asian men. So 1 in 4 black men are likely to get prostate cancer in their life, and we have in the Thames Valley, as everywhere throughout the UK and the world, there's a large cohort of Afro-Caribbean men, and that's not demonstrated in the cancer statistics, is it? So I think we need to be very observant and help our men from our black communities to access PSA testing, because generally black men are more likely to get prostate cancer, probably get it at a younger age, and possibly get it in a more aggressive fashion. So that's a very key element to our to what we need to look for in terms of case finding. Now, some other those top three, age, family history, and race, are absolutely the key ones. Then there's other ones which I think are not necessarily to encourage us to check PSAs or to go seeking prostate cancer, but they are things that may or may not increase or decrease the risk of prostate cancer, and are things people will ask about. So obesity is another area that increasingly evidence is suggesting that there's a higher chance of having prostate cancer with obesity. The mechanism we're not quite sure, although I suspect the feeling is to do with around testosterone and testosterone receptors, and whether that's causing some change in the way the prostate cancer cells are developing. But there's no doubt that obese people we are finding that they're having a little bit more prostate cancer. Now, whether that is also because they're not necessarily seeking out healthcare as well as other groups is another indeterminate at this point. The flip side is exercise is shown to be protective. Again, whether that's related to hormonal effects, we're not sure, but there's lots of work going on in that, particularly in Oxford and in the Thames Valley, Reading, but no definitive evidence on that at the moment. What there is definitive evidence from relatively old studies was there was a whole raft of studies looking at vitamin supplements and prostate cancer, and the SELECT trial from 2011 actually had to be stopped early because they discovered vitamin E, for example, increased the chance of prostate cancer, so they stopped giving them vitamin E, and they also found that folic acid possibly increased the chance of causing prostate cancer as well. It was a epidemiological study, so not as good as the SELECT study, which was a randomized controlled study, but in men taking multivitamins with folic acid in their 50s and 60s probably shouldn't be. Again, the mechanism was, but it was suggested that it might be something to do with the DNA methylation, but again, I'm not sure the mechanism has been fully studied in that. And then other areas, diet. So no hard evidence on any of these things, but weak evidence for things like soya, seeds, green tea, vegetables, tomatoes, pomegranates, and the flip being animal fat not being so good. Now, I would argue that those are all just good, healthy diets, that we need to be perhaps eating a little less meat and a bit more veg, and eating a nice Mediterranean selection of tomatoes, fruits and vegetables and seeds is probably a good thing for our health, full stop. I do say to men, though, that you don't need to have a tomato only diet or spend all your life savings on some of these concoctions that are sold as miracle cures for prostate cancer because they contain a little bit of pomegranate. The evidence is weak, but a healthy, balanced, probably slightly more vegetable-based diet is certainly a positive. We've talked about obesity and exercise. Smoking, general increased cancer-specific risk. I don't think we've pinned it down to prostate cancer. People ask about whether sex or anal sex are likely to cause it. No evidence. STDs, no evidence. Vasectomy, no evidence. Cycling, no evidence. Cycling does increase prostatitis, and as a result, men get prostatitis and get examined and investigated a bit more. So I think there's an incidental higher rate of hit rate in men who have prostatitis because they seek out our help. But I don't think there's any clear evidence that the chronic inflammation from prostatitis causes prostate cancer. But again, there's a lot of work going on that. There was an interesting study looking at kind of boron in water, and in that area, the prostate cancer levels were lower. Maybe a coincidence, but we don't know. So those are the main risk factors. Age, family history, and race are the key ones. Everything else, not strong evidence. So I do generally tell men you can do very little to protect yourself from prostate cancer, but you can do lots to make yourself live to 90 by living a healthy life, losing weight, taking exercising, and having a sensible diet, which I think is probably a message you guys are, well, we are all forever trying to sell.
Thank you, Tom. That's a very useful summary of information and a few new things there, especially the vitamin E. The audience is very quiet today. Maybe they're just chilling with the sun and enjoying it really, rather than being interactive. So we want a few questions, but can I ask you a question, Tom? Why do you think Black men are possibly more at risk? Is there something about anything there?
I think there's probably two elements to it. One is some genetics. As we know, there's a genetic component to prostate cancer, and I think that, but also Black men have naturally higher testosterone levels, and there's no doubt that a higher testosterone is what drives prostate growth forward and drives prostate cancer forward. Hence, we give anti-androgens to hold it back sometimes. So I think the naturally occurring higher testosterone levels probably put them at a slightly higher risk.
Okay, that's really useful. So Tanya Ali has put a question saying, you mentioned folic acid. Is this more or less likely to cause prostate cancer?
More, sorry if I was unclear. Yeah, so that study, which was an epidemiological study, so I think they were looking for for answers rather than asking a question and then finding it. But there was a 9 versus 3% rate of prostate cancer. More men had prostate cancer if they'd had folic acid supplements. So my takeaway from that is probably men in their 50s and 60s probably shouldn't be taking folic acid, because I'm not sure what the benefit to them is. It's slightly different if they're trying to have families and things like that, where it can influence fertility, can't it?
Okay, lovely. Well, thank you very much. If you have any questions, please put them in the chat. I'm going to move on to referrals and how and quality referrals for prostate cancer. So we all know that a quality referral is necessary for specialists to make an accurate diagnosis and develop an appropriate treatment plan. We all know that. And really, it's essential that the appropriate patients receive timely and appropriate care, which then leads obviously to better outcomes and quality of life. So that's a quality referral. And I think majority of us actually do that probably, but I'm just stressing the point that actually consider the patient. And in terms of process of referral, one of the key things is patients being able to attend within 2 weeks of the referral being made. And certainly if they can't because they're away on holiday or something else is happening, then please hold on to the referral and make when the patient is available again. And clearly in that process, safety netting is going to be important because you don't want to miss the referral. Next slide, please. So really, I mean, I think prostate cancer referrals are a bit of a quandary for us, really, because we've just heard that it's the second most common cause of cancer-related deaths in men, roughly 13%. And we also know that from Tom's slides there, that most men die with, but not because of prostate cancer. So it's a bit of a dilemma here compared to other cancers. We also know that over the last 20 years, prostate cancer mortality has dropped by 20% or more. And incidence, however, has gone up by 50% or more. So, you know, we are at a place when we're diagnosing a lot of men with prostate cancer without altering their outcomes majorly. Obviously, individual cases are different. And so therefore, in primary care, it is really difficult to work out which patient requires a referral, or are we just over-diagnosing it and making the referral? So it's a bit of a dilemma, really. And there are two problems we face, really. First of all, symptoms correlate very poorly with the underlying disease, in that LUT symptoms are very common in men with the enlarging prostate in a benign fashion, and is estimated to be present in over 80% of men over the age of 60. So LUTs is a very common symptom, and the PSA test is also both poor sensitivity and especially specificity, because the PSA can be high in benign prostatic hyperplasia, after ejaculation or after severe exercise or prostatic stimulation. So PSA test is a little bit of a difficulty here, but we do need to understand it. It's also high in UTIs. Next slide, please. So when making a referral, obviously we will probably almost certainly need to do an examination really, and digital rectal examination is really quite important to do, because you can then work out if the prostate is asymmetrical, has induration, nodularity or hard mass, and definitely feels malignant. And in that case, it's absolutely essential that you make a suspected cancer referral. We need to see the patient or check the urine to make sure they haven't got a urine infection, because as I said, PSA can be raised in urine infections. And it's useful to carry out some blood tests before making the referral so that the eGFR can be ascertained for imaging purposes. The PSA obviously, and the PSA tells us, and the guidance we're following is the age range PSA, and I've listed here the age range you should be following. And obviously anemia is quite important, because if they're having an operation, it's important for them to know what their HB levels are. Next slide, please. So when we look at PSA, it's important to wait 2 days after ejaculation, exercise or prostatic stimulation before measuring the PSA, and also treat a UTI if the urine dip has actually shown an infection. Wait for 6 weeks before measuring the PSA, because it will be abnormal. Obviously, if the prostate feels malignant, then make the referral. But if the PSA is just over threshold but less than 20, then repeat the PSA 2 weeks later. And if the PSA is greater than threshold, make the referral. If it's less than threshold on second PSA, repeat the PSA 12 months later or earlier if the symptoms are progressing or you're alarmed in any way at all. Clearly, as I said, if the PSA is over 20, make the referral. Now, patients, obviously prostate cancer or prostate symptoms are in the older adult, and they will have multiple sort of illnesses. And in patients compromised with multiple illnesses or have a less than 10-year life expectancy, you do need to discuss with the patient and the family or a urologist as an appropriate measure, because actually the risk of prostate cancer, if the PSA is less, if the PSA is within normal range, is less than 10%. If it's between 4 and 10, then the risk of prostate cancer is 20%. If the PSA is greater than 10, it's 30%. Greater than 20, 50%. So actually, we do need to understand what the actual sort of prostate PSA level means for the patient in those respects. And remember also, there is someone who is on finasteride and dutasteride. The PSA level will be about half over a 6-month period. So remember that when you're testing, make sure that it's understood what the PSA level refers to. These are just sort of thoughts and notes for you to consider when checking PSAs, because also actually one important factor that I really must bring to your attention is the performance status of the individual. We all know performance status relates to the patient's ability to carry out daily activities and tasks, and can be affected by a variety of things like age, various illnesses, and also stage of severity of their cancer or other illnesses. The question I really want you to be asking when you're considering doing a referral or a test is the do no harm ethos. As physicians and clinicians, we must not do harm to patients. So can the patient undergo invasive assessments like a biopsy or even the surgery? And can they even get on the couch for their MRIs, imaging? Very careful and very important to understand that. And so therefore, assessing a performance status is very important, because we need to make sure that the patient receives appropriate and individualized care. Now, it may be that if their performance status is very poor, you may need to refer on to an alternative pathway. It may be you seek advice from the urologist and through advice and guidance or an urgent referral. Because we know that poor performance also, patients may be at increased risk of complications, either from the testing or treatments, will certainly take much longer to recover and have a high risk of complications. And of course, they may not be suitable for any aggressive treatment. So, patients may not be able to go through prolonged anesthetics when they have the robotic surgery, for example. Conversely, patients with a good performance status are more likely to tolerate the testing and treatment, as well as recover and rehabilitate better, and of course have a further aggressive treatment. So performance status is really important in this group of patients. Next slide, please. So performance status can be assessed by various tools. The ECOG tool or the Rockwood or the World Health Organization tools are often used. And these tell you ranges from 0 being fully active to 5 being dead. And it's quite important to put into the referral and very important to assess when you're assessing the patients. Also very important is to consider the patient factors, which is, does the patient understand why the referral is being made and is happy to have that? Do they understand the benefits and risks? And do they understand that they have a choice of treatments? In urology, as we will hear later on, there are a variety of choices. And also make sure that you're safety netting, having assessed the patient and imparted the advice. So that's quite important for you to understand. Next slide, please. So in summary, really, in terms of referral, is that for high quality referral to be made, include the patient demographics and the contact details, clinical history, past examination, past history and medications, examinations, the blood tests, which I've highlighted for you, performance status, and information given to the patient with their wishes. And really all of this should be within the form. So please complete the form very fully if possible. There's a question in the chat box actually, which Tom, you might want to help answer, which is clarify the place of DRE in referral. If the PSA is raised and the right safety measures in place, we can refer anyway. Asking the patient to come in for a DRE is an extra appointment, takes time. Tom, in your opinion, is it still necessary?
So, you know, I think, Dr. Seacombe, I think it's appropriate to send someone without a DRE. I think there's three things that always worry me. Not worry me. I get it takes time to do the DRE, and not everybody's doing them all the time, so not always that helpful. So, providing they've had 2 PSAs done a minimum of 2 weeks apart, and it's obviously a bit raised, of course, I think they should just be referred. There's the small group of patients where they've got a low PSA and we're worried about symptoms. They do need, that's when, those are the ones that I wouldn't want them to be just dismissed just based on their PSA, because I would often, that there is a small group who have high risk prostate cancer with low PSA. So I think if they've got a high PSA, refer them up. If they've got a borderline or low PSA and there's some debate about whether they should be referred, then the DRE adds quite a lot of weight. And then the third thing I think which we keep harping on about, if they've got a really strong family history or they're black men, then they may have a low PSA. Then they should, you know, we should have a lower threshold for referring them or examining them. You know, 2 PSAs, 1 is not enough.
So Tom, can you explain that a bit further? Because Sarah Morton has asked who needs 2 PSAs. I went through the slides, but if you could explain that, that'd be really great.
Pretty much everybody needs 2 PSAs unless the first PSA is over 20. But for that group where their PSA is between approximately 3 and 20, we'd like to see, you know, we need to know particularly particularly the low. I mean, I get if their PSA comes back at 11, it's unlikely to fall back to within the normal range within it. But the UTI, exercise, sexual activity, that can all push it up quite easily. I've seen it go up with COVID, with the COVID jab, flu, general inflammatory changes. So 2 PSAs 2 weeks apart, other than if it's over 20.
Thank you, Tom. Carry on. If you're talking about diagnosing prostate cancer, Tom, carry on.
I think, for, Sarah, I think with RBH as well, they would be keen for that as well. That's their nice guideline, certainly. So prostate cancer diagnosis, which I think this is the next phase. So once you've all made your excellent referrals, and you know, again, summary, we would like to see anybody you're worried about. And it's the slightly aggressive 2-week wait offices that can bounce things back occasionally. Whenever I see someone, I'm delighted to see them, whatever, really, because you know you're busy and we are here to look after those men, aren't we? However, so when they get to us, and it varies a little bit across the patch, how they get their pre-biopsy MRI. In some areas, they are booked straight by either by yourselves or via a kind of triaging service, or sometimes they'll come and see either one of our nurse specialists, and Shana, I think, who's here on call from GWH, or in elsewhere. They may well get their MRI booked by someone within the hospital, but every man nowadays, providing they're able to, will have a pre-biopsy multiparametric MRI of the prostate prior to any biopsy. And there will be a group of men for whom that's it, because if the MRI comes back showing a PIRAD score of 2 or less, the chance of significant prostate cancer, clinically significant prostate cancer, is less than 10%. So at that point, we will often advise them, this is the risk. We wouldn't recommend a biopsy at this stage. Now, some men say, well, the risk of around 10% is very high, and I still want a biopsy, in which case we offer them a biopsy. Most men will say, thank goodness I don't have to have a biopsy. And hopefully most of my colleagues refer them back, discharge them, saying, if their PSA goes over a certain number, please re-refer. I think gone are the days when if it rises 20% year on year or by 0.75 nanograms per mil, please send them. I hope that everybody's giving an absolute number, and it's more of an art than a science, to be honest, at that point. But that would be my preference. If my colleagues aren't, you're well within your rights to ask or make an assumption yourself and say, well, it feels like it should be this much. If their PIRAD score, and I'm going to show you a picture in a moment, is higher than 3 or above, then they'll go on to have a biopsy. And prostate biopsies are notorious in that they are notorious in causing infection and being worrying, and there's a lot of activity going on in that area, and I'll just talk about transrectal versus transperineal in a moment. And then once they've been diagnosed, they'll get a Gleason score, and there's a number of treatment options at that point, but quite a lot will have to have staging completed with either a PSMA PET, which is prostate-specific membrane antigen PET, or an MRI of the skeletal system or the marrow to complete their staging. So just to so just for the, I'm sure some of you may have seen these kind of pictures. What multiparametric, if a patient asks you, and multiparametric MRI means basically one 45-minute MRI generally with contrast. Now, some centres do it without contrast. In Oxford and in Reading, I think everybody gets contrast. In Wickham, they don't always get contrast. I'm not sure what happens in Swindon. In Milton Keynes, which is kind of on the edge of the patch, they get contrast. There are studies going on about whether we could speed it up for patients without having to give contrast. But effectively, it's an MRI with several different sets of images in it. And if there is an area of interest, so something that doesn't look quite right, they look at it in one image. So, for example, here in T2, and say, oh, look, there's something that looks a little worrying. So then they will look at a contrast and say, oh, that's glowing, so there's a little bit more contrast there. And then they might look at some of the special MRI characteristics that you can look at in terms of washout and things, and say, oh, look, it's still an area of interest. And then finally, diffusion weighted images again. And if that same area flat comes up on all the different parameters, so multiparametric, that raises the risk of there being prostate cancer there. And they give it this PIRAD score, which is something prostate imaging radiology, some diagnostic score, and it's a score out of 5, as you may have read in letters or know about. 5 means there's a kind of generic highly likely to have prostate cancer. 1 means very unlikely. To put a bit of numbers on it, if there's a PIRADS 5 lesion, there's about a 70% chance of there being clinically significant prostate cancer. Clinically significant being Gleason 3 + 4 = 7 or above. A PIRADS 4 lesion, it's about 50-50. PIRADS 3, it's about a 30 to 40% chance. PIRADS 2 are going down to 10-15%, and PIRADS 1 practically is normal, effectively. So just a 5% PSA related risk of having prostate cancer. And the radiologists are very good at this. It is best if it's a radiologist who's used to looking at them, and you will get a bit of disparity between them between radiologists. Their safe bet, like a lot of for all of us, is to go for PIRADS 3 because it means something will happen. They're very happy to nail their colours to the mast on the 4s and 5s, and they have to be very confident that there's nothing in the 1s and 2s. So we see a bit of each. We then biopsy, and so there's several slides here, but it's a kind of, I'll keep on talking as we go through. So the two options for prostate biopsy that men will get faced with are either a transrectal biopsy. So you can see from this diagram, the rectum is just behind the prostate, and there's the water pipe, urethra is running through it. The perineum is just above the rectum and adjacent to the prostate. And prostate cancers could be anywhere. Commonly they are, I don't know if you can see my mouse, you probably can't, but they're in the posterior aspect, but we do see them anteriorly as well. So, and on MRI, we're getting more and more information as to where these lesions might be. So then we're able to try and be more precise with our biopsies. So transrectal biopsy, we've all been doing for years. And it's a probe in the bottom, and the needle goes up through the rectum into the prostate. And we try and use our MRI imaging to try and target anything but also take systematic biopsies in a kind of fan shape through the prostate. But as we know, the needles are going through the rectum, so there is a chance of urosepsis. We give it varies a little bit from trust to trust, but everybody doing a transrectal biopsy will get some sort of pre-biopsy antibiotics. Usually a combination of either ciprofloxacin and metronidazole, occasionally gentamicin. But still, I think the given rate is about a 1 to 2% chance of significant infection, urosepsis needing admission after a transrectal ultrasound, and there's about a 1 in 1,000 chance of going to ITU, and the incurring risk of mortality as a result of that. We do a lot of biopsies. And my feeling is that the transrectal biopsies, when done properly, the risk of infection is low, and you never can quite predict who it is. But clearly, men with diabetes, immunocompromised, obese are at a higher risk than the others. So the alternative is these transperineal biopsies. So rather than put the needles going through the rectum, they go through the perineal skin. You don't have to have any antibiotics, because it's just like a blood test, for example. For someone who does a lot of these, it is actually, I think it's easier to get a feel for where you're passing the needle through. So you're not kind of trying to work out at angles, it's all square, simple surgeon's mind. So it enables us to target lesions both in the posterior aspect, deep into the prostate, and anteriorly. So the consensus is that probably LATP, so it's shortened to local anaesthetic transperineal biopsy, LATP, and you'll see that written in letters quite often. So LATP probably has it definitely has a lower infection rate, probably has a better pickup rate, but is possibly a little more uncomfortable because you're putting needles through multiple punctures through skin rather than necessarily through the rectum, which is in theory less sensitive. Now, there's a big trial in the region going on called the Translate trial, which you've seen up in the corner, which is a multi-centre trial throughout the UK, randomising people for LATP and TRUS, because we don't know the actual answers to all those things I said probably to. And we've recruited nearly 1,000 men, most of which have been in Oxford, Wickham, Milton Keynes. I don't think Reading are actually doing this one, but they're fully aware of it and supportive of it, as well as other areas in the country, and that should be reporting this autumn to nail it. Early data from trials in America suggests there's not that much difference. So we're going to have to decide as a group what the best way to do it is, but we await that. But you will see the various different acronyms, LATP, TRUS, or perhaps a GATP, in the letters about how men have had their biopsies, and they're all slightly different experiences. So that is the diagnostic pathway. and then they end up with a Gleason score. I didn't think you needed. I didn't think you'd want to hear a long talk on Gleason score. So effectively, I've just got one slide on it to say you'll hear two scoring systems nowadays. One is the Gleason score, which is the old-fashioned two scores where the pathologist looks at the slide and looks for the two most predominant areas of histological change that you can see here and gives them a score out of 5, 3 effectively being cancerous, 1 and 2 being benign, and then you combine them to give a score out of 10, with Gleason score 10 being highly aggressive, poorly differentiated prostate cancer, and Gleason 6 being very low risk, well differentiated, highly unlikely to spread prostate cancer. And the kind of difficulties come because you go Gleason 3 + 3 = 6, 3 + 4 = 7, 4 + 3 = 7, 4 + 4. So there is a newer system which you might see in letters or in the research or reading you've done, which is the grade group, where it's been split into 5 groups. Grade group 5 is Gleason 9 and 10, so the very aggressive prostate cancers. Grade group 4 is Gleason score 8. Grade group 3 is Gleason 4 + 3 = 7. Grade group 2 is 3 + 4 = 7. And grade group 1 is Gleason 6. So, and I think patients find that easier as well. Group 1 being very low risk, 2 a bit more, 3 a bit more, 4 being quite high risk, 5 being very high risk. And I see that Dr. Aziz has just asked about what's the prognosis if you've got MET. So just this nicely segues into staging, which will read T1, T2, T3, 4. Classically, the majority get diagnosed with T2. T1 is generally found on a TURP. The T3 is when it's palpable outside the prostate, so that DRE done for another reason, or in a man with a low PSA and you can feel a nodular prostate. Those are the guys who've probably got more advanced, locally advanced disease. We see it on MRIs now. And then the clinical staging, nodal disease is seen on the MRI or possibly the PET scan, and metastatic disease is generally seen on either an MR marrow or a PET scan now. Lots of centres are still doing bone scans, and you can see from that bottom right disc, it's that kind of mottled look on the bones with lots of dots, often in the ribs and spine to begin with. A PET scan is pretty state of the art. Lots of centres are doing it. We can't quite work out who the best people to do it on. It's quite an expensive resource. We've gone from a period of doing very few to doing an awful lot, and now we're paring it back a bit to try and image the people who really need it, so the high-risk prostate cancers. So the risk of, if you have bony mets when you're diagnosed, doctors, is there, in the old days, we used to say that 5-year survival was 35%. However, in the last 5 to 10 years, there's been an explosion in other treatments. So abiraterone, enzalutamide, lutetium treatments, different types of SABR radiotherapy. So if you speak to oncologists now, they'd probably say it's more like 50 to 60% survival at 5 years if you're diagnosed with metastasis at the start of your progress, but start of your diagnostic pathway. Good. So I think that's the kind of diagnostic bit. And then I don't think we haven't got long, and I wasn't going to go on for ages about what the treatment types are, because there are all sorts. But effectively, men, I think the 3 take homes I'd like to say is that, one, we are pivoting to much more active surveillance in men with Gleason 6 and Gleason 3 + 4 = 7 prostate cancer. You may have been aware of a great big trial called the PROTECT trial, which has been randomizing men between active surveillance, surgery and radiotherapy for the last 15 years. And at 15 years, there is no difference in survival for men who've had active surveillance versus surgery versus radiotherapy for those Gleason 7 men. There's about a third more chance of having metastatic disease, but they're all still alive and they're 15 years older without having had treatment. So when these men come to see us in clinic, we need to be very clear that if you've got kind of low to intermediate risk cancer, they're not about to fall off their perch. They've got a lot of time to think about what the right options for them are. And it might well be, particularly for those men in their 70s, to not do anything and to take the worrying thing, take the metastatic issue in their 80s or 90s, rather than their 70s when they're fit and active and wanting to do all sorts. So that's a conversation we're having more often. But there are lots of options. Radical surgery, robotic surgery, which I do a lot of, radiotherapy, which my oncology colleagues do a lot of, and I've got all sorts of new WYSI devices. Focal therapy is increasingly becoming part of the decision-making process. It's a small group of men. It's probably only about 10% of men, and we're about to start another clinical trial looking at focal therapy with things like HIFU, high-intensity focused ultrasound, and nano knife and cryotherapy to see whether we can really pin down who the men benefit from it are. And I think I'll stop there, if that's okay.
Yeah, thank you, Tom. That was a very comprehensive run through of what goes on in prostate cancer currently. We're very useful, but quite a few questions, but because of time moving on, I think we'll go on to secondary care and follow-up. I don't know if Sean Fletcher's with us. Are you with us, Sean?
I am, Anand.
Oh, fantastic.
Yes,
welcome, Sean. Yeah, thank you very much. Yeah, lovely. Thank you for coming along. Just let me know when you want to move the slides.
Our slides, there's very few of them. We nearly didn't really worry about them, to be honest. My colleagues Zoe and Cyrilla are also, I believe, on the line. Zoe and Cyrilla are the cancer nurse specialists. And basically, Anand actually had a big contribution towards stratified follow-up. So it was really just to inform sort of primary care, that, stratified follow-up is coming. It may be already in your areas of work. For Swindon, we're a little bit slower just getting the software sorted. But so stratified follow-up really is enabling patients with stable prostate cancer after treatment that don't have any significant problems to go onto a programme of surveillance, which will be by telephone or letter, not necessarily face-to-face. A lot of this does go on already, but we will be using software to sort of hopefully align the clinics and help us moving forward. And actually, we will be aiming to move our patients out into primary care for follow-up once they've completed treatments and they're stable at possibly a 2 to 3 year time frame. I think historically, we often have a 5-year mark, and certainly in Swindon, we're still following prostate men up for many years, even decades, to be honest. So we're trying to align the Thames Valley Cancer Network with some guidance around stratified follow-up. We're hoping that it will really streamline patient follow-up, improve their experience and outcomes. It will be individualized to those patients, and so making sure, because after you've had treatment and often you get a normal PSA, that normal PSA might not be normal for that patient that's had treatment. So it's making sure that GPs and ourselves are very aware of what the most appropriate PSA is for that patient for referring back in once we have discharged. We hope to promote well-being, recovery and empower men and, individuals to live well and actually take a more active role in their care moving forward. So it will be setting expectation at the beginning of their cancer journey, really. Next slide, please. This is very blurry, I'm afraid, but this is the framework that will be being utilised moving forward. We are re-looking at this in Swindon and might be making some minor adjustments, but this was the Thames Valley Cancer Alliance group. There was a lot of work done and undertaken, and this was sort of what we decided would be. So depending on your patient and what they're having, be it watchful waiting, radical prostatectomy, hormones, plus or minus radiotherapy for a period of time, and brachytherapy, there's going to be some guidance on when we will follow them up in secondary care and then move them out at which points to primary care and at what point they could be referred back in. Next slide. So for Swindon, Zoe is actually sort of taking a bit of a lead on this in Swindon for us. So she's currently working on the pathway for patients. As a team, we're starting to inform patients that they will be moving on to a stratified pathway in the future. We are slightly adapting the Thames Valley Cancer Alliance criteria for our hospital here. And unfortunately, we are still waiting for our software to be able to initiate this. So I appreciate it's a really short sort of update, but it's all it's all in progress, really. It's not a definitive thing, but Anant will certainly be able to probably answer more questions than I might be able to, as he was very key in this document. And
No,
Tom, of course.
Sean, no, I think you guys have made it happen. I just talked, all right? So that was good. But really, I mean, I think that's really great to see this and share this with everyone, because we're likening cancer now, and particularly prostate cancer, like a long-term condition, aren't we, really, whereby we're expecting follow-up to be carried out in multiple systems, and primary care is well-placed, if happy to accept, which triggers back into secondary care. Tom, someone's asked a question about what determines who gets transperineal biopsy rather than transrectal biopsy?
Yeah, no, I saw that, Mike. Thank you. Mike, I think that, well, there's two ways. Firstly, within the trial, they're just randomized. So that's happening currently. But as a rule, currently the guidance is primary biopsies are truss in Oxford. I think in Wickham they're LATP, and in Reading they might be LATP as well, actually. But the absolute indication for an LATP is those diabetic immunocompromised people, or if we know they've got an anterior lesion, i.e. one that we probably couldn't get from the rectum, then they definitely need an LATP. And then anybody who's having a second biopsy, because the first one was inconclusive, has an LATP as well. So an increasingly large group would be having an LATP regardless. My sense is that, well, I'm second guessing the trial. In some places, London, everybody gets an LATP nowadays.
Okay, thanks for that. Martin has asked the question: healthy man with a normal PSA, when should he have his next one?
So obviously it depends how old he is, but and whether he's got any other risk factors. But if he's no family history, no other risk factors, I often say, you know, one age 60, and if that's well within the range, and if it's less than one, never again. If no more than every couple of years would be my view. There's not a good sign. You know, screening is annual, isn't it? We don't screen in the UK. So once we've had one that's normal, it probably should be related to symptoms, or related symptoms, or the patient's worry. But I would advise it's normal, don't worry.
Thank you very much. Yeah, thank you for that. And before we go on to the next slide, thank you for the speakers, Sean and Tom, really great, and Gloria for setting up the slides. You've been amazing, all of you, really, really useful. The next slide, men with raised PSA but not rising normal MRI, when should MRI be repeated? Philip asks.
Yeah, no, and again, it's another one. So if they've had one normal MRI, if they've had a normal MRI, i.e. PIRADS 1 or 2, and their PSA was normal, they kind of raised, and they've had some it depends on the size of their prostate. We look at their PSA density, which I didn't talk about today, but obviously the PSA density is the volume versus the PSA. If their PSA density is less than 0.15, which is approximately 4 for a 40 cc prostate, then if it's lower than 0.15, I wouldn't bother doing anything more until their PSA started rising. If their PSA is high and their prostate is small, I would still not get another MRI until their PSA started rising. But I'd have a higher level of suspicion because it's out of kilter.
Okay, that's really useful. Thank you. I mean, I think whilst you're thinking of more questions, can I ask you, please scan the code or go on the web? We need some feedback from all of you. That'd be really great on today's event. We want to look for any things we can improve, including any future topics. But the next Lunch and Learn is on the 8th of June. We're going to be reviewing the FIT fecal immunochemical test and the guidance and the new guidance that have come into being in the last 6 months or so. Further resources on this and other cancers. Really, Gateway C is a fantastic free resource commissioned by Health Education England. Please look at Gateway C. There are lots of modules. You'll get lots of points, lots of fantastic points for your appraisal. Well worth completing some of the modules. The Cancer Research UK Health Professional on the a bit of modules on the website gives you lots of information. And of course, this webinar has been recorded, and the other series of webinars that have been recorded in the past will be available on the Cancer Alliance website as well. So hope you found that useful, and thank you for the speakers again. Really grateful for giving up the time and sharing your wisdom. If there's any queries or questions, please get back to us. But thank you all very much, and look after yourselves and have a good sunny day. All the best. Bye.
Thank you, Anand.
Thank you.
Bye.
Bye.
Bye-bye.